Thank you for joining ComForCare and At Your Side Home Care for this informative Dementia-Wise webinar, How to Minimize Frightening Hallucinations and Delusions that can happen as a result of dementia. Please let me welcome our host, Director of Special Populations, Dr. Deborah Beer.
So glad you could be here for this important topic. We'll talk today about common hallucinations and delusions with dementia, frequent misidentification of them, drug treatment and overtreatment, successful non-drug approaches, and additional resources in your local community. This webinar is for educational purposes only, and the information provided is not intended to be diagnostic or serve as a substitute for actual medical advice. If you have concerns about your or your loved one's health or diagnosis, please seek help from a licensed medical professional. Let's talk about common hallucinations and delusions with dementia. And first we're going to talk about hallucinations, and I want to define them. Hallucinations involve sensing things while awake that appear to be real, but instead were created by the brain. And this can occur in any sensory modality, sound, visual, touch, and things that we don't necessarily think of as our senses, things like our sense of danger or safety, our sense of passage of time. But the most common types have to do with visual and auditory hallucinations. Now, while there are many hallucinations that people with dementia may have, one thing we need to watch out for is to not confuse them with Charles Bonnet syndrome. Charles Bonnet has to do with visual impairment, does not have to do with cognitive problems. This happens where people have lost vision and their brain is stimulating itself with imagery. And most people, including many physicians, have never heard of Charles Bonnet, but the person who experiences it can be very frightened by it and think they're going crazy or have developed dementia. And with Charles Bonnet, people see detailed hallucinations that seem very real, but they know that they're not. And there's no auditory aspect to it. It's purely visual. And the visions are not usually scary, but having them can be scary. And what they see are either complex patterns or faces, and sometimes the faces can be scary. They might see very detailed people, children, landscapes, animals, buildings, and these are typically smaller than life. And the funny thing about the Charles Bonnet hallucinations is that they interact with the environment. For example, you might hallucinate a bird landing on a very real windowsill. So that in that way it interacts, the real and the unreal interact. It's not useful to do any psychological analysis of these particular hallucinations. They don't yield anything. It's just the brain stimulating itself. Can be triggered in times of low light, or while they're not doing much activity, such as watching TV, and it generally lasts 6 to 18 months. Charles Bonnet is not related to dementia. Let's look at delusions now. Let's define delusions as a belief held with strong conviction, despite the fact that there's no evidence to support it. Evidence to the contrary exists, and it's logically absurd. Suspicious delusions are quite common with dementia. I think that's the most common type of delusion. They're not always delusions, and we'll talk about that in a moment. There is a Capgras delusion. It's also called the imposter syndrome, and while it's not common, it's not as rare as the textbooks say. It's just underreported. Capgras delusion involves the person with dementia believing that someone who's important to them in their lives, let's say a spouse or a child, an adult child, looks exactly like the real thing, but is actually an exact duplicate, an imposter. Now, seems like a crazy delusion, but it's not something you can argue someone out of. Let's look at how hallucinations and delusions are frequently misidentified. I think there are a lot fewer hallucinations than are reported, and I think part of that fault has to do with our mistakes, that we don't understand what the person with dementia is communicating to us. It also has to do with the person's miscommunications and misperceptions of what they're seeing. They're more errors in judgment than actual hallucinations. It may also be that their hallucinations are actual hallucinations, but they're not from dementia. They may have to do with some other illness or disease, or be an effect of drugs, side effect of drugs, or drug interactions. And here's a couple of examples for misperceptions. Someone who can no longer recognize themselves in the mirror or in reflected glass sees themselves and says, "Oh my God, I saw an old woman looking at me through the window." Well, that's not a hallucination, that's an error in judgment. But when we hear that, we might go, "Oh, there is no old woman looking at this person. This must be a hallucination." So they make an error, and then we make a second error. Another fairly common thing is when people are watching TV and they're at a certain point in their dementia, they can no longer tell the reality of what's going on TV versus what's actually in their room. And they may say, "There's a man with a gun in my room," and it's really a crime show. And there is a man with a gun, but he is on TV, and they can't tell the difference. That, again, is not a hallucination, but we might mistakenly think it is. And actually, these are all somewhat logical, considering how distorted their judgment is. So how can we tell dementia from a delusion? And that's really hard. Sometimes it may actually be impossible, particularly because of the communication problems that people with dementia have. But it may actually be normal confusion, and we're the ones who are actually getting more confused. They are confused about so many things. How is it that we can tell the difference between a real delusion and their dementia, and their normal confusion from the dementia? And I think that persistence and consistency can help make that distinction. For example, Capgras may come and go. They might not always see that person as an exact duplicate. They might sometimes see them as the real thing, but it's the same theme, and that's the persistence and consistency. So let me give you some examples about the suspicious types of delusions that people have, or the suspicions that people have with dementia that maybe aren't delusions. A woman who keeps moving her purse around but can't remember that she's moved her purse may come to the conclusion that someone keeps moving my purse. Well, it sounds pretty suspicious, but I think if you or I couldn't remember moving our purses, we might come to that reasonable conclusion. Another person might look for their family silver and forget that it had been given away years ago and say, "The family silver's been stolen, call the police, we've got a crime." Again, it's a problem with memory, but it's not a delusion that people are stealing from him. It's a logical problem. Another person may be remembering something that she owned as a child, and of course those memories from way back are very strong and persistent, and insists that she had a blue and white necklace, and it was right here a minute ago, and well, a minute ago was actually 50 years. But she can't, her sense of time is distorted. And all of these things make a lot of sense, and maybe they aren't really about suspicion or delusion. There may be more about memory loss. Let's talk about responding to the Capgras delusion, because that is a difficult situation to live with. Most of the time, people in the environment, the person who is being accused of being the duplicate, is outraged and upset, and they try to argue with the person and say, "Well, of course I'm your real daughter. Are you kidding? I've known you my whole life. How can you think that?" And then try to prove to them that they're the real McCoy. Well, arguing is not effective with people with dementia. They have broken logic and poor memories, and you can't convince them in a way that they'll remember that you really are the real thing. So, important thing is just to keep calm and continue to be loving and continue to be warmly connected to the person, because otherwise the person with dementia is going to feel disrespected, or that you're manipulating them because they're already suspicious because you're not You're not the real thing. You're an imposter. And then that was going to cause even more difficult behavior and resentment and anger. So try reassuring the person that that you're there to take care of them and spend time with them and to make sure that they're safe. This may or may not be effective because once you're the object of suspicion, it's hard for you to be the one to straighten out the problem. Some people believe that visual recognition is the real problem and that people with dementia will recognize a voice and know it's the real person versus seeing them. Now, what we think is going on there is they recognize visually that this person looks exactly like their loved one. But that feeling of familiarity is disconnected from that visual recognition, so it seems like this can't be the real person. But we think that that may remain sometimes through their hearing and recognizing the voice of the person. So first of all, the person who's suspected of being the imposter should withdraw and leave the room. And then return a little while later, but start talking before you're in sight. And speak lovingly and warmly and say the kinds of things that you would normally say that you'd be recognized instantly by your loved one. And see whether or not by the time you're in sight, that person knows that you're the real thing. Let's look at drug treatment and overtreatment. Normally, people with hallucinations or delusions, or those we have decided have them, they're given prescription medication, and that's usually antipsychotic medication, also called neuroleptic medication. Sometimes they receive benzodiazepines or hypnotics, and a benzodiazepine would be something like a Klonopin, Valium. These are not appropriate drugs for people with dementia. They're vastly overused, and they're dangerous for people with dementia. In fact, the FDA has required a black box warning on these drugs because they're associated with higher rates of functional impairment and disability, worse health outcomes, physical injury, usually in the form of falls, increased rates of hospitalization, and greater emergency room use. These are not drugs that have benign effects. They are used as last resorts properly and only for a short amount of time, but they are normally and typically used for all kinds of behavioral problems, including hallucinations and delusions, but not limited to them. Our federal and state governments and healthcare organizations are working very hard to reduce neuroleptic usage for the dementia population, but we're not even close to there yet. Now, one thing we need to think about for antipsychotics is, does this person have Lewy body dementia? Now, with Lewy body, and by the way, Parkinson's dementia is a form of Lewy body. With Lewy body, the person has more hallucinations and delusions than with any other type of dementia. So those are the people who are going to be getting the antipsychotic medications. However, people with Lewy body are really sensitive to medications, and the wrong neuroleptic can cause swift decline and rapid death. Seroquel is often noted as the best type by physicians who are treating Lewy body, and only giving it at minimal doses. So the best advice about antipsychotic medication, coming from dozens of researchers and healthcare organizations and government sources, is that they should be used very sparingly with dementia and only when there is a threat of violence or harm to self and others. And then they should only be used for 2 weeks and not as an ongoing drug, as they're often used for months, if not longer. They recommend that using non-pharmacologic interventions much better. So let's talk about these non-drug approaches. There is a better way than medication. Medications are not appropriate for difficult dementia behavior and very often not appropriate for hallucinations and delusions associated with dementia. Research shows that behavioral and environmental interventions are safe and highly effective with dementia. And compared to drugs, they create a much better daily life for people with dementia and their families. Dementia-wise is made up of all of these non-pharmacological interventions. They're all having to do with behavior and environment, including for meeting hallucinations and delusions without drugs, and difficult behavior in general. So the first thing we would do with someone who we believe is having hallucination or delusion is make sure if the person is upset that we connect with them warmly, make eye contact, contact with voice, and if it's safe to go near them and touch them, use touch to contact them and help them be calm. And it's important for you to be calm because the person with dementia will pick up on your emotions if you're not calm. And if you're upset, they will be upset. So it'll be very hard to tell whether or not the hallucinations or delusions upset them or they're just upset because you're upset. So you want to tell the person who has had, if they've had a scary experience, that he or she is safe with you and you will not allow anything to harm them when you're there. And then remove the person from the area where they had that upsetting experience. And then get them involved in something calming, some kind of favorite activity that's going to help them feel safe and reconnected. And I would do that for the rest of the day after they've had this frightening experience. Be very important for you not to argue or try to convince them that their experience wasn't real. No, you didn't see that or you didn't hear that. There's no such thing. That is not going to work with someone with dementia. Giving them comfort and creating a sense of safety are what is important. So if the person has had hallucinations or delusions, whether they're upsetting or not to them, it's important for you to reach out to their physician to see if there are some possible causes such as an illness or medication problem, and then correct those if they exist. And consider possibly not medicating them with antipsychotic drugs if their experience is not upsetting to them. They might even enjoy some of their hallucinations. So once you have a treatment plan that you can carry out from the physician, it might be a wait and watch and see whether or not they have the experience again. Let's look at additional resources that are available in your local community. If you're a family member with someone with dementia or a healthcare professional managing dementia patients, caregivers, or families, our offices can assist with strategies and solutions for your dementia care challenges. Please contact your local ComForCare or At Your Side office for information and about our dementia care services. And if you're interested in Dementia-Wise and learning more, there are many features that we haven't covered in this session. Look for Dementia-Wise presentations and family caregiver support groups held in your area. Sign up to receive free information about dementia care and other topics by visiting ComForCare.com and AtYourSideHomeCare.com. Thank you so much for joining us.